Hello everyone. Pediatric rhabdomyosarcoma, and to be more specific, genitourinary rhabdomyosarcoma, are true example of intense teamwork and multimodality approach. As an radiation oncologist, to treat these patients is a real challenge, from decision making, technique selection, radiotherapy planning, precise treatment delivery, and finally quest for minimal side effect and optimal outcome. As per intergroup clinical classification, it represents post-surgical extent of disease at the time of chemotherapy initiation. This is very important, at the time of chemotherapy initiation. Group 1 designates localized disease that is completely resected, while Group 2 patients have grossly resected disease with microscopic residual and or nodal disease that is grossly resected. Group 3 is classified as gross residual disease after an incomplete resection or after biopsy alone. And finally, Group 4 consists of those with metastatic disease at diagnosis. If we look at the TNM staging, so staging for pediatric rhabdomyosarcoma employs a TNM system, but also takes into consideration the primary site of the disease. So stage 1 disease, stage 1 tumors are favorable site and can have any T or N designation. So remember, if the favorable site is there, then it doesn't matter whatever the T or N stage is. If it is stage 2, then stage 2 tumors are unfavorable site but must be T1A or T2A and with negative lymph nodes. A and B are classified on the basis of size. A is less than or equal to 5 cm and B is more than 5 cm. And T1 and T2 are classified on the basis of invasiveness. If it is confined to the organ of origin, then it is T1, and if it is going beyond the organ of origin, like it is infiltrating, going to adjacent structure, then it becomes a T2. So coming to stage 3, so tumors, these tumors are in unfavorable sites and are either T1B or T2B or N1 or both. Stage 4 tumors are any site with hematogenous metastasis. So among genitourinary rhabdomyosarcoma, bladder, prostate, perineal and perianal are considered as unfavorable site, while vagina, vulva and uterus are considered as favorable site. Among histology, embryonal is most common and it has botryoid and spindle subtype. Botryoid has the best prognosis, while alveolar histology has worst prognosis. At present, children's oncology group utilize risk stratification, and this is based on histology, site, stage and clinical group, as we have seen in our previous slides. So low risk rhabdomyosarcoma is defined as a localized embryonal rhabdomyosarcoma arising in favorable site with any clinical group, group 1 to group 3, or embryonal rhabdomyosarcoma arising in unfavorable sites with either completely resected disease or microscopic residual disease. Intermediate risk RMS is defined as a non-metastatic alveolar rhabdomyosarcoma arising at any site or incompletely excised embryonal rhabdomyosarcoma arising in an unfavorable site. And high risk are patients with metastatic rhabdomyosarcoma, group 4 stage 4 disease. Majority of cases usually present in intermediate risk group. Risk group is highly predictive of overall survival, and it ranges from 98% for a low risk to 78% for intermediate risk and 30% for high risk disease. Over 4 decades, cooperative groups have utilized various multimodality approaches and have tried to rationalize the role of chemotherapy, surgery and radiotherapy in a way that it has resulted in improved outcome. Further studies also found that cytogenetics as a tool to define prognosis in these group of patients, especially alveolar subtype, There are clear evidence that that fusion status portends poor prognosis. Considering the importance of cytogenetics, I have included this one slide here. Specifically, alveolar rhabdomyosarcoma is usually characterized by one of two translocations, both of which involve FKHR transcription factor gene or FOXO1 transcription factor gene on chromosome 13. So transcription factor FOXO1 fusion with transcription regulator PAX3, this translocation, the incidence is 60%, and this has the poorest prognosis. The event-free survival was 54% in Children Oncology Group D9803 study. While transcription factor FOXO1 with transcription regulator PAX7, the incidence is 20%, and event-free survival was slightly better, which was 65%. Altogether, if the alveolar RMS is fusion negative, it behaves more like an embryonal RMS. So these are the remaining 20%, and the event-free survival is almost as good as embryonal RMS. So in the tune of 90%. If I have to define the role of radiotherapy in RMS, this one slide represents the summary. There is only one category where radiation can be omitted beyond any doubt, and it is fusion negative, localized disease, which is completely resected and is node negative with negative margin. Rest, if margin is negative or microscopically positive and regional disease is N0, then 36 Gray is recommended. While for regional nodal disease, that is N1 on resection, is treated with 41.4 Gray. And finally, if gross residual disease is there, then 50.4 Gray is a recommended doses. Genitourinary rhabdomyosarcoma. Why is it different? Surgical quest for negative margins leads to functionally debilitating outcome. There is high propensity for lymph node involvement, paratesticular RMS specifically, and this leads to a complex treatment decision algorithms. As such, it is a challenge for radiation oncologists because there are many critical structures which are surrounding the target. Traditional control rates have been poor as compared to other sites, so one needs to be aggressive with regard to therapeutic outcome. But at the same time, we have to optimize the therapy in such a way that we have better functional outcomes. So for all these reasons, delivering radiation in this subsite is an immense challenge. We have to deliver adequate doses to adequate volumes so to achieve optimal local control, and at the same time limit the acute toxicity, and more important, reduce the late toxicity and preserve the organs and their functions. Being a pediatric age group, increased relative risk of second malignancy is 1.2 to 1.5 and is another important issue to address. Cumulative incidence of second malignancy is less than 1% at 10 years, while at 20 to 30 years, it ranges between 4 to 11% in different cities. So this again is a challenge in this particular age group and subsite. Bladder and prostate is most common subsite, constituting 50% of all genitourinary RMS. At the start of the IRS-1 study, pelvic exentration was used for aggressive tumor control. Then efforts were made to reduce surgical morbidity by combining chemotherapy and radiation with a more limited surgery. Despite a high rate of complete responses, primary chemotherapy and radiotherapy without surgery resulted in higher rate of disease recurrence. The bladder preservation rate for IRS-1 were quite dismal at 23%. IRS-2, with more rigorous chemotherapy and limited surgery and using radiation for residual disease, or if an exenterative procedure was needed, was done. Although all patients ended having radiation, surgery or both. Bladder preservation rates, though initially thought to be high, 97%, but the percentage of patients who were alive and had functional bladder was only 22%. In IRS-3, radiotherapy was routinely administered to all patients at week 6 and after induction chemotherapy. Again, this chemotherapy was intensified as compared to IRS-1 and IRS-2. So after 6 weeks after induction chemotherapy, radiation was given, except those in whom complete tumor removal was possible without total cystectomy. So the result of IRS-3 have been gratifying. The bladder retention rate at 4 years was 60% and survival was 90%. Finally, long-term outcome revealed that bladder retention rate was 54%. Finally, IRS-4 recommended treatment regimen which continued their efforts to maintain bladder function while achieving optimal cure. Overall survival was 82% and bladder preservation was close to 70%. IRS-4 attempted to formally evaluate bladder function through patient questionnaires. Only 40% of all patients on IRS-4 had normal bladder function. So bladder function preservation is very important along with tumor control. So considering the importance of this particular entity, I have incorporated a case which is a 4-month-old baby having an RMS prostate on biopsy. So it was a clinical group 3. And on MRI, pre-chemotherapy MRI, the prostatic mass was 3.6 to 3.6 into 4.4 centimeter with a loss of perivesical planes. So it became a T2A disease. Inputs here was taken from pre and post chemotherapy MRI for designing the radiotherapy target volumes. And one can see that critical structure in this region that should be considered includes bladder, rectum, bowel, pelvic and femoral head growth plates, penile bulb and testes, and so many. You can see on the left hand side of this particular panel, radiotherapy planning screen panel, there are so many critical structures which has been delineated on this CT scan. So our target is being surrounded by organs which we intend to spare. So this is in itself is a very complex scenario. Thanks to modern technique, specifically intensity modulated radiotherapy technique with the help of image guided radiotherapy, which definitely help us to achieve our therapeutic goal. We'll discuss these modalities very briefly in my next few slides. So with regard to this particular case, 36 gray in 20 fraction pre-chemotherapy volume to pre-chemotherapy volume was given, and a boost of 14.4 gray in 8 fraction to post-chemo residual volume was given. This patient is undergoing radiation at this particular time. Gynecological tumors, which include vagina, vulva, cervix and uterus, these are rare and account for approximately 4% of the cases. Within this group, vagina is the most common site of origin. For female genital tract, the rate of hysterectomy decreased 48% to 22% and use of radiation increased in unresectable tumors from 23% to 45% as compared to the earlier IRS studies. Analysis of data from the IRS-4 and IRS-5 studies have revealed high rates of local failure for vaginal tumors when surgery or radiotherapy is omitted. So current guidelines from COG committee call for radiotherapy in all patients with post-surgical microscopic or a macroscopic tumor. So local treatment modalities recommendation as per the radiotherapy is indicated. This is indicated for patients receiving low or a zero cyclophosphamide doses and or patients achieving less than complete response after induction chemotherapy, and whenever radiation is being indicated, brachytherapy is the preferred modality. Considering vaginal RMS, to begin with, radical surgeries are always being omitted unless lesion is very small and one can go ahead and do surgeries with complete removal of tumor without any functional defect or without any poor cosmetic outcome. So To begin with, only biopsies are being done, followed by induction chemotherapy. And if there is a complete response, then one can consider radiation if there is a low cyclophosphamide doses or if the patient is fusion negative. Whenever there is a partial response and if R0 organ preservation operation is not possible, then radiation is being considered. And once the whole treatment is being done, then close follow-up is required, which is 3 monthly for the first 2 years, followed by 6 monthly for the next 3 years. As in my earlier slides, I was focusing on brachytherapy. Whenever we are using radiation, we should basically use brachytherapy. This is the apparatus which is being used. One of the apparatus which is being used. This is a cylinder which is being inserted into the vagina, through which a central catheter is there, and through this the radiation source passes and delivers the radiation. This actually delivers the high dose of radiation to the vaginal mucosa, and at the same time it spares the whole critical structures which are surrounding this organ. And nowadays what we use is a high dose rate brachytherapy, and the dosages are 27.5 to 36 Cray, which is being given in 5 to 12 fractions. These fractions are delivered twice a day, so usually treatment is over within a week. It ranges between 3 to 10 days. Paratesticular RMS is mostly embryonal type with high propensity for lymphatic spread. Radiation was given to group 2 and 3 patients routinely in IRS-1 and IRS-2, while IRS-4 had inferior failure-free survival as compared to IRS-3, 68% versus 100%, and the reason for the same was omission of retroperitoneal lymph node assessment, which was replaced with CT scan. CT was not able to pick nodal disease as effectively as retroperitoneal lymph node assessment, and thus misclassified patient to group 1, and in turn these patients received inadequate chemotherapy, resulting in inferior outcome. So now the consensus is, if a child is less than 10 years and CT scan is negative, then no retroperitoneal lymph node assessment is being proposed and one can proceed to systemic therapy. But if CT is positive, then one should proceed with retroperitoneal lymph node assessment. While if age is more than 10 years, then irrespective of CT scan findings, one should go ahead and proceed with retroperitoneal lymph node assessment. And finally, all patients with nodal disease should receive radiation irrespective of the response. Same is evident in this meta-analysis, which was recently published a couple of years back in Journal of Clinical Oncology. It included 12 studies conducted by cooperative group. No retroperitoneal lymph node assessment for patients with more than 10 years and primary tumor size of more than 5 cm resulted in inferior event-free survival at 5 years, 91.2% versus 67.4%. And the same was true for same subgroup of patients who received radiation versus no radiation. Here event-free survival was 88% versus 70.1%. So these findings, they do imply the importance of retroperitoneal lymph node assessment and the importance of utilizing radiation in these node positive patients. Whenever we talk about radiation, and specifically for the pediatric age group, we are very much concerned with the side effects, and which is actually important in this particular age group. So how do we plan to mitigate or to decrease the side effect of radiation? So there's been various approaches. One is to shrink the volumes of radiation, or to reduce the dose of radiation, or to use the newer advancements or technological advancement and to apply them in our radiotherapy planning, and to individualized brachytherapy treatment schedules, as brachytherapy is a very highly conformal form of treatment, and moving beyond traditional photon based radiotherapy, which is basically a proton radiotherapy. So I will be very briefly touching these aspects in my next slides. As one can see that radiotherapy volume and doses over a period of time has definitely gone down. To begin with, to initially the approach was to involve the whole muscle compartment in our radiation field, to the recent or the current studies, group studies where we are only taking 1 to 1.5 centimeter margin beyond the gross tumor volume. And also now it has been shown that the reduced radiation dose does not compromise local control for patients with microscopic tumor after surgical resection. So we don't increase the dose. Whatever dose is for R0, 36 gray, is the same for the microscopic residual disease. And the further there are ongoing studies, we are further decreasing the dose to 36 gray in patients where the node is positive. Presently it is 41.4 gray. So utilizing the modern radiotherapy techniques, so if we look at one of the most important technique is an intensity modulated radiotherapy. Here, if we consider this as a body and this is a tumor, so to cover this tumor with a conventional radiation, it will cover like this, and any critical structure which is very adjacent to this tumor will also receive the same amount of dose. So our dose to the tumor is being limited by the tolerance doses of these critical structure. But when we are using IMRT, the tumor is being covered like this in IMRT, and we can spare the critical structures from the high doses, and thus we can deliver the tumoricidal doses to the target area, and at the same time we can spare the critical structures from the high doses of radiation. Thus we are doing the two things together. We are achieving the tumor control, and at the same time we are trying to preserve the function of organs at risk, and thus trying to have a good quality of life along with the cure of disease. And how one can achieve this is with the help of these multi-leaf collimators, which are dynamically moving as the beam or a gantry is moving along the tumor, along the arc, and thus modulating the intensity of the radiation. And how this looks like when it is delivering radiation, you can see the red or the orange color here is the high dose of radiation. So as in the beam path there is a critical structure, there is a low dose which is a blue. As there is a tumor in that beam path, then it converges to a high dose. So intensity of this beam is continuously changing as the gantry is rotating around the patient. And this is being complemented with the image guidance. You can see these panels which are coming out. They prior to delivering the radiation, the patient goes through a CT scan, which is an inbuilt process within a linear accelerator, and whatever the changes are there in the position, rotational changes, translational changes, these are being applied, and then we can deliver the radiation. So utilizing this IGRT approach, our margins are further reduced, and thus we can have a very small margin along the target area and can deliver the radiation properly and with a very precise and targeted, in a very precise and a targeted. And now there is an evidence of using these approaches. There are new techniques with reduced CTV margin, and this overall philosophy of using newer techniques with reduced margin doesn't increase the local recurrence. In this particular series, the local recurrence, local failure rate was 10.4%, which compared favorably to those reported by COG for D9803 trial, in which the overall local failure rate was 19%. And there was a very interesting finding in this study. The cumulative incidence of local failure for patients with a residual FDG uptake after chemotherapy was 18.2% versus 0% for patients without residual FDG, showing a trend towards statistical significance. Radiation toxicity in this series was comparable or less as compared to historical series, overall 5 to 30% less for various subcategories. And finally, this study clearly demonstrates the relationship of increasing dose and volume irradiated with long-term toxicity, suggesting the role for newer techniques like protons. So proton therapy has an immense potential, specifically in this pediatric age group patients. And now there are some data which is coming up specifically with regard to rhabdomyosarcoma. The local failure rate is comparable to the various IRS studies. At the same time, there is a definite reduction in late effects when it is being compared to previously published series. So there is a lot of potential, though still the data is coming out, and this is one particular subsite where protons are definitely helpful. So there are some ongoing investigations, the future studies, where, as I have already mentioned, that now the groups are trying to reduce the dose to 36 gray for patients with group 2 node positive disease as well. There is a ongoing study for patients with group 3 disease where they are treating the pre-chemotherapy volume to 36 gray followed by a boost to 50.4 gray versus 59.4 gray. So now this study is a dose escalation study if the initial size was more than 5 centimeter. So these are the subgroup of patients having a poor outcome, and here we are trying to increase our therapeutic outcome by increasing the dose 59.4 gray. And also a very interesting application of modern technique in patients where there is a bone metastasis. So treating bone metastasis with stereotactic body radiation therapy. This is a very highly conformal form of radiation, and probably this may also have an important role in the management of this particular disease.